Dear audience, I welcome you to the 18 months progress report of my scientific projects, which are in the context of my future PhD thesis, coming with the title, The Role of Endoscopic Interventions in the Management of Pancreatobiliary Diseases. I am Bálint Gellért. I am an internal medicine specialist and a GI fellow, and my vision with my work is to reduce mortality and morbidity related to pancreatobiliary diseases. And I wish to achieve this via enhancement of the safety and efficacy of different endoscopic interventions used in managing these disorders. To make this reality, I am currently working on two specific projects. The first is about understanding the role of different ERCP techniques in post-Roux-en-Y gastric bypass patients, and the second is about improving the endoscopic management of ward of pancreatic necrosis. So let me introduce you the first one. Roux-en-Y gastric bypass is a bariatric surgical operation, which creates a very difficult anatomical situation for endoscopists when the examination of the bypassed organs is required, for instance, an ERCP in our case. And the three most widely recommended and widely used ERCP methods in these patients are the enteroscopy-assisted ERCP, the laparoscopy-assisted ERCP, and the so-called edged endoscopic ultrasound-directed transgastric ERCP. The problem with these techniques is that their safety and efficacy profile are quite controversial, because those with the higher technical success rates have also been associated with higher overall adverse event rates as well. This casted some doubt on the therapeutic decision making, which we would like to dispel with our work. So we formulated a clinical question whether there is any difference between these ERCP techniques regarding safety, feasibility, and clinical success rates. And after screening more than 10,000 articles, 67 were included in the final analysis. And now we'd like to show you our results. So this slide presents the proportions of successful access to the papilla of Vater, which is naturally a crucial point of this procedure, as most common reason behind procedural failure is the failure to reach the papilla of Vater, especially in the case of enteroscopy-assisted ERCP. And we calculated proportions with 95 confidence intervals and then pooled them together, and these pooled proportions were compared to each other in case of every ERCP technique. And our results show that enteroscopy-assisted ERCP yielded not just statistically lower results, lower access rate to the papilla of Vater, but this difference is also of clinical significance as well. And this difference grew even larger when we were examining the ERCP success rate. But when calculating overall complication rates, which is depicted on the slide, then we can see that although enteroscopy-assisted ERCP yielded lower complication rates, but this difference didn't reach the level of statistical significance, which definitely contradicts the results of previous studies available in the literature, which you may remember I showed you in the background part that this was this difference, so this complication rate for enteroscopy-assisted ERCP techniques was significantly lower compared to the other two. So as a summary, we say that our study has several strengths. We included only patients with Roux-en-Y gastric bypass anatomy, and also included only patients who underwent ERCP, and we paid a great amount of attention on the statistical independence of data, so we calculated only with one result per patient, which is in comparison to previous meta-analysis on the subject is we can say that these are strict criteria. And as far as limitation go, I would say that unfortunately most of the included studies were retrospective in nature. Due to the many case series included, we had to calculate indirect comparisons, which naturally lowered the quality of evidence. And we should not forget that the variation of expertise among the endoscopists may have influenced the results of the included studies. As a conclusions, I would say that enteroscopy-assisted ERCP shows not just lower technical and clinical success rates, but its superiority in safety over the other two techniques is at least doubtful. For clinical implication, I would say that edge and laparoscopy-assisted ERCP should be preferred over enteroscopy-assisted technique. And for research implication, I would suggest that more prospective studies are needed in this subject. Also, cost-effectiveness studies could be helpful in decision making, and factors influencing edge should be analyzed more thoroughly. The manuscript is currently under review by the Journal of Pancreatobiliary Pancreatic Sciences. It's our fourth trial. Now, I would like to continue with the second project, which is about the comparison of two endoscopic treatment strategies in the management of ward of pancreatic necrosis. Acute necrotizing pancreatitis is sure you know, it's a terrible disease with very high morbidity and complication rates, and its mortality is still unacceptably high. There are many or some international recommendations helping in the management of this disease. And they also include some suggestions for the management of its late local complication, the ward of necrosis, which is particularly a necrotic mass with a well-encapsulated wall. And these recommendations include that this ward of necrosis should, if the intervention is required, then they should be treated either by surgical, percutaneous, or endoscopic interventions. And if it's possible, then the endoscopic interventions should be preferred, which usually include the placement of metal stents or plastic stents between the GI tract and the necrotic cavity. But the former one has the advantage that it makes possibility to enter the necrotic cavity with an endoscope and perform a necrosectomy directly there, so a debridement from there. But there are many unanswered questions regarding this endoscopic treatment of this ward of necrosis. But we would like to focus in our project on the timing and choice of necrosectomy, whether it should be done in an on-demand fashion or in a scheduled way. So we wish to look for a composite of major complications, mortality as primary outcomes, and for the technical success rate, total number of necrosectomies needed, and resolution time, and also cost effectiveness as secondary outcome. This is a plan for a clinical trial which was not started yet, but as I said, the first project was already submitted. So I would like to thank you for your attention, and would remind you that you should be careful about reading health books, as you may die of a misprint. Thank you very much.
Congratulations, excellent meta-analysis. Do you have any data? How many of these procedures, I mean, for the first project, Roux-en-Y ERCP, done until now in Hungary?
Unfortunately, I have no data about it.
Less than 10, I think, both three.
I thought so too. But who knows what the future will hold.
Did you study the adverse events? Were they related strictly to the ERCP procedure, or were they related to the way how the ERCP was approached? I mean, the laparoscopic procedure, the edge procedure, or how do you explain the difference in the adverse events?
The complication rates were associated with the procedures itself. I mean, not the ERCP, how the scope was advanced to the papilla, and probably because of the fact that many enteroscopy-assisted ERCP trials failed, also resulted in lower adverse event rates. But it's also the case that lower experience in edge, and probably laparoscopy-assisted ERCP could have also influenced the higher adverse event rates in many centers. So, I mean, compared to enteroscopy-assisted technique, these are completely new. Edge was invented in 2014 and used only in Western countries in a few centers. So, great experience in EUS, and the EUS guided gastrogastric drainage and gastrogastric tunnel making is, I think it's a difficult part of the procedure.
Okay, do you have any data about the edge? How many of them was a two-step procedure? I mean, first doing EUS guided drainage, gastric, and waiting. Sometimes we should wait not to move the stent. So if you are in urgent situation and you have to do urgent drainage, I think this edge is not suitable for that reason.
Of course, or it's very risky at least. So most of them, I would say more than 90% of these patients were the double session procedures. Yes.
Necrosectomy. First was on demand, and the second was regular. What was the timing of regular? Was it similar in between studies, or it was just regular but not the same regularity?
Yeah, I would say that regularity would mean in our study that it should be performed in a 3-4 day intervals. Because a pilot study on our center was performed a few years ago, and it was the procedures were scheduled in these intervals, and most of the also results from the literature were also carried out in this time interval.